Hello, I'm Charles Mathias, the Health Policy and Communications Lead for the Rural Telementoring Training Center. I'm here today to tell you about telementoring solutions for incarceration healthcare. For many of you, you're aware that healthcare for rural America has some important differences than it does in our urban centers, both in terms of the needs of population living in rural America, but also the ways that we do the workforce to take care of their needs. I'm here today to talk to you about a similar kind of cultural adaptation for the care of persons who are experiencing incarceration. My outline describes three different goals today. First is to talk about policy changes in healthcare for incarcerated persons, then telementoring solutions for implementation and workforce, and finally, introduction to the telementoring toolkit. So first thing to be aware of is just a significant portion of our incarcerated population actually is detained in rural settings. Between a quarter and almost 40% of our institutions that house persons who are incarcerated are in rural areas. So there's a significant footprint there, and they're major employers for many of our smaller communities. One thing to be aware of when it comes to incarceration is that there's kind of different phases or different areas where people are incarcerated. One is jails, which tend to be shorter term stays and involves detention in many cases while someone's awaiting trial or before they're adjudicated. And then there's prisons, which people are in after they've been adjudicated, and they tend to be longer stays. So if we think about at any one point in time in the United States, there's about 2 persons in prison for any one in jail. But because jail stays are brief and people cycle in and out of them quickly across the entire year, we actually have more people detained in jails at about a 6-to-1 ratio. So thinking about those population size differences, those come with some differences in healthcare needs. So for the jail population, they tend to have a lot of high acuity needs, whereas prison healthcare focuses a lot on management of chronic disease. And if you look at this next figure, the right 2 columns shows the proportion of persons who are detained either in jail or prison and the type of health needs they have. So you can see higher rates of substance use and mental illness in jails, whereas we see more hypertension and infectious disease and obesity in prisons. So these have a lot of implications for the entire rural community around a jail or prison, and it's not just factors that impact the incarcerated persons themselves. Because if we don't treat health conditions, they're going to bring those needs back to them when they return to the community. And 95% of people who are ever detained will return to the community. And if their health care is not maintained during incarceration, it increases the likelihood of recidivism and return to police contact again. There's also some immediate financial consequences for the local community. So for the earlier slide, I showed you very high rates of behavioral health and substance use needs in jail. The biggest single payer for those services is Medicaid. And Medicaid covers at the federal level between 50 and 77% of the cost of that care. But during periods of incarceration, those benefits are suspended and all the costs get shifted onto the local county or state budget. So there's a cost shift involved with healthcare when people are experiencing incarceration. And this rule about Medicaid has been around since Medicaid was first started. But there's recently been a big push, especially by the National Association of Counties and Sheriffs, to get some relief with just the budgetary constraints that this poses, their ability to provide care in jails and prisons. So there's actually the 1115 waiver program, which is a Medicaid sponsored program that states participate in to access certain blocks of funds. For the first time ever, has allowed waivers that will reimburse for Medicaid services during periods of incarceration. California just got the first one of these approved, and there's 14 other states who have these pending. So what are these, what kind of billing is going on here? So what it does is it doesn't cover the entire period of incarceration. The California bill actually, what it does is does a process called in-reach, which means we're going to bring services in to the system as people are starting to approach return to the community. And their plan actually covers a full 90 days before release. And that allows them to do a couple important things. One is do a screening and real thorough medical evaluation to understand like what the needs are and what the treatment services they have been receiving, and then align them with service providers and community supports. So as they come out, they have a continuity of care and are coming out of incarceration with a treatment plan that keeps them stabilized or allows them to gain access to additional services that they'll need for their health care. So 1115 waivers are one policy change. There's actually another one that went into effect with the Consolidated Appropriations Act of 2023, or the Omnibus Budget Bill. This one had two different provisions that specifically dealt with Medicaid and CHIP billing. This was limited to juveniles, so youngsters who are in detention, that would allow them to have screening and case management prior to release, so those last 30 days before they return to the community. But the second one of these actually allows Medicaid and CHIP billing during pre-trial detention, which is between the time they're originally booked in and when their case is settled. And for some individuals in certain jurisdictions, that can last for quite a while. So it's a brand new provision. It's really a lot of community groups are thankful to have these new resources coming into the system, but at the same time, it does pose some real challenges for healthcare delivery. The first of these challenges is just implementing new programs. You know, currently the way jail and prison healthcare works is it's funded by the local county or the state, and it's staffed in one of two different ways. One is they might hire their own full-time health professionals and be internal employees delivering this care, or they might contract with community providers to come in and provide this care. And as we implement a new system that allows for billing in a kind of more fee-for-service type way to get reimbursements, that creates a lot of opportunities for making changes to how we're going to staff these positions and the array of services that can be offered. I think what we'll see is there'll be an interest in broadening the array of services that are available. And I think that's going to create some implementation challenges as these new policies come into effect. Because we're going to have to set up new systems for how to do that Medicaid billing and make sure that we're meeting all the quality metrics that are necessary to get those reimbursements. And this is where I see telementoring as being a really important solution. I think the operational and implementation demands that gets created by these new programs can be solved by telementoring connections to other experts. So what is this? I've been using this term throughout the talk, telementoring. What exactly is that? So telementoring is just the use of telecommunications technology to deliver training, education, and support for health workers. So it's really a modality to connect at distance, you know, a learner or a person in need or someone that would benefit from additional information, and connecting that with an expert somewhere who has that information or has already kind of worked through this process. So I think it's an important way in this context to avoid local jurisdictions from having to kind of invent the wheel for how they're going to make these healthcare practice changes and work collaboratively to figure out best practices. So there's a number of different use models. It can be about clinical knowledge and task shifting, and that's the first thing I think many people think of. It's about clinical knowledge, but it actually is much more expansive than that. Telementoring can be used for professional development and network. It can be workforce development and training, or it can be about operations and doing rapid implementation. I'm not going to go through all of these, but I'll just point out that telementoring, you can use a variety of different modalities to get telementoring out there. We have modules that talk about individual consultation, webinars, online modules, podcasts, ECHO, and adapted community health clubs. And I won't go through all these on this talk, but I'll refer you to our website at the end where you can kind of get more detail on how each of these work. And the reason why it's important to be aware of these different modalities for delivering telementoring is because they kind of will meet different audience needs. And depending on, if you need a training to be live, or if you need to be something that people could access during off hours or asynchronously, you might choose different ones, or the level of interaction that you would like between your audience, that can help you guide you on which one you select. So there's a variety of tools out there, and what service that we provide is we help you kind of match the tool that you're selecting with that best fits your needs. So I alluded to these challenges that the new policies for reimbursement of incarceration healthcare pose. And off the top, I think its implementation is going to be a major challenge. I've had a pleasure of talking to local jurisdictions around the country, and I think this is what everybody's talking about, is how do we implement a kind of a whole new way of documenting and delivering healthcare within the regulations that come with processing Medicaid claims. So for telementoring, I think what it does in that space is provides operational guidance and technical assistance. With the new funds, we are going to have to rethink how we do the workforce, and especially for rural communities, the number of available applicants to these jobs is going to be limited. So it's important that we maximize the attractiveness of what we're offering in these positions. So for workforce recruitment, telementoring can address lifestyle and professional development needs and provide that network, so people aren't feeling like they're isolated. They are part of a community, including a professional community. And for workforce retention, telementoring can provide ongoing mentorship, training, and support that offers practical feedback, and again addresses that isolation issue. And then I think the last thing that we're going to be facing with these new changes is just the need for specialty care in incarcerated settings, and just a lack of specialist availability. And one workaround that we've seen be very successful for that is just upskilling the workforce. We've been involved with, for instance, an ECHO project that allowed primary care providers to manage and treat and cure hepatitis C with telementoring to specialty care or gastroenterologists. For the last section, I just want to discuss our new telementoring toolkit. So this toolkit is launched as part of an overall program and agenda that we've been working for in the Rural Telementoring Training Center, where we have been doing training and supports and technical assistance, and that is meant to be available for organizations that serve the rural community, and it's not tied to any one disease or specialty. But since the beginning of this program, we've been developing background on this toolkit so we can know better, how to assess what we're accomplishing when we do telementoring. So the evaluation toolkit does a couple of things. It gives us some standardization on what we think are the most important metrics. We want to get past just attendance counting. You know, if we're doing a webinar and we have a large number of people sign up, that's one measure of success, but it doesn't tell us a lot about quality or what kind of behavioral change that we're producing out of that. So that's what we've been looking to accomplish in developing this toolkit. And I think it's really vital to have good assessment when you do telementoring, so you can understand, you know, what is your return on investment. So this takes time out of your provider's schedule to participate in these activities. And on face value, it seems clear, like it's important that they're able to keep up with these kinds of engagements. But the toolkit actually gives you some metrics behind that to let you know what the benefits really are for participating in these activities. So if you're interested, we'd love to connect with you. I've got a link up here with a QR code that will take you to our training site. With our new mobile app, it kind of accomplishes several different things at once. One, it kind of walks you through the different models of telementoring and can help guide your decision making on which one might suit your purposes best. It can connect you through the training and technical assistance pathway, which kind of walks you through an onboarding process to get assistance from our experts. And then the last is just the telementoring quality and measure toolkit that I was discussing on measures and metrics. I really look forward to engaging with you and like to keep this conversation going. I'll just conclude with how to connect with us and be in touch. Thank you.